All right, welcome back. This week's this week's lecture is covering the urinary system. On this set of notes on these slides, we have this as chapter 16, but in our textbook, this is chapter 9, the urinary system. The normal book has it at chapter 16, but the online version is chapter 9. All right, so let's see what we got here. It looks like the urinary system is pretty busy, as this is the list of functions. Excreting, this means to get rid of, right? So when we excrete something, we're releasing it to the outside. So aqueous waste, so getting rid of the liquid wastes. Maintaining your fluid balance, maintaining your blood composition and blood volume. Remember, we maintain blood volume. We could change blood volume, and we do that by changing the levels of plasma that's in the blood, which is the liquid component of the blood. Composition refers to the cells that are present in the blood. We could regulate those as well. Blood pressure, these kind of tie together with maintaining fluid balance. That's how we maintain blood pressure. Red blood cell levels are monitored by the kidneys. There are cells in the kidneys that are detecting the levels of red blood cells, and then there's a hormone associated with the production of red blood cells. It's called erythropoietin, that's secreted from the kidneys. The vitamin D synthesis, adjusting ions in the blood. We use some ions to help control the pH of the blood, and those are hydrogen ions and bicarbonate ions. Maintaining blood glucose levels and producing hormones that regulate calcium levels. So remember, calcium is stored in the bones. So there's a hormone that we can use to promote the release of calcium from the bones, and that hormone is coming from the kidneys. So with each heartbeat, a quarter of the blood flow from each heartbeat is sent directly to the kidneys. And after 24 hours, 184 liters have been filtered in and out of the kidneys. But, just because we're sending 180 liters of blood through the kidneys a day doesn't mean that 180 liters is being excreted. Only a small fraction of that would be excreted. Somewhere between 1 to 2 liters of urine would be released. So these are the organs of the urinary system. We have a kidney over here. This is the right kidney. We have a kidney over here, the left kidney. These are adrenal glands that sit on top. These are not part of the kidney. Then we have a couple of tubes. We have the renal arteries that bring blood in, and then we have the renal veins that bring blood out. And then we have these specialized tubes that carry the filtrate, which is going to be urine, that was just recently filtered from the blood, all the way down to the urinary bladder, which is down here, the urinary bladder. And then we have the urethra, which allows the urine to exit the body. So here we are, pretty much in a nutshell. We have the kidney, the ureters, the bladder, and then the urethra. There's a little bit of protective fat around each kidney. A lot of your vital organs are protected in fat, right? They have a thin layer of fat around your heart, your liver, right? So your kidneys are no exception to that. There's an outer membrane called the renal capsule. The space where the renal artery enters the kidneys, that space, that area is called the hilus. And the hilus is also the same area that provides an exit point for the renal vein and as well as for the ureters. Remember, the ureters are extending from the kidneys all the way down to the urinary bladder. So that area where these three tubes are going in and out, we call that the hilus or the hilus, whatever you want. We do see these structures inside. If we would take a cross section of the renal of the kidney, you do see these structures that look like pyramids, and these pyramids become visible as a result of the accumulation of what are called collecting ducts. And as the collecting ducts receive urine from the filtering units, they kind of all converge, and they generate this appearance of pyramids inside. All right. Next to the hilus, we have the renal pelvis, and this is where all the collecting ducts kind of converge to. All right, and it's through the renal pelvis that where urine is collected, and then the urine would be transferred to the ureters. And what's inside urine? Well, urine has nitrogenous waste that have been filtered from the blood. So there's nitrogen-based waste in the form of urea that we need to have removed. All right, so all the waste materials removed from the blood are leaving the body in the form of urine. So this is a good cross section here. On the outside, we see that strong membrane, the renal capsule, going around. This region here, this area here, you see this is a little bit lighter in color. This goes around the outside. We would call this the renal cortex. And a little bit deeper to that, that's where we would find these renal pyramids here. These are the renal pyramids. And the renal pyramids are found in the area called the renal medulla. That's where we see these pyramids. These pyramids would all lead to this area here, which is the renal pelvis. So this is the renal pelvis area, and this is where the urine is all kind of converging, and all the urine, the collecting ducts that are part of these renal pyramids would send the urine down into the ureters, where it would go down to the bladder. It's at the hilus here that we see, here's the hilus here, that we see the renal artery going in, the renal vein leaving, and the exit point for the ureters as well. All right. So this is a cartoonish version. Over here is a real picture, but you can see all the same stuff. So out here is all renal cortex. Here's our renal pyramids. And here's marking where the renal medulla is, renal pelvis, and then the hilus capsule goes along the outside. Ureters. Here's a ureter here. Erythropoietin. Remember, erythrocytes are red blood cells, right? That's kind of important to know. Erythrocytes. So erythropoietin stimulates the production of new red blood cells, or the production of new erythrocytes. Calcitriol is a hormone that helps to maintain the calcium levels in the blood. So let's look at filtration. Blood enters the kidneys via the renal artery. So this renal artery is carrying unfiltered blood. this blood is rich in wastes. Once inside the kidney, the renal artery branches into smaller arteries. And then these smaller arteries continue to branch, forming into the interlobular arteries that will then dive between the renal pyramids. And where they're going is they're going through the pyramids. The goal is to make it to the outer edge near the cortex, because it's in the cortex that the filtering units of the kidneys begin. They're going to continue to divide into smaller arteries until they're in what is called an afferent arteriole. The afferent arteriole is what's going to bring this unfiltered blood into the functional units of the kidneys, which are called the nephrons. All right, and then the blood will continue to move through different arteries as the filtering process continues, including the efferent arterioles, and then the peritubular capillaries. There's peritubular capillaries, and we'll get into what those are in just a minute. All right, so the filtered blood, after it goes through the afferent arteriole and after it goes through the filtration process in the beginning of the nephron, will then leave the glomerular portion, and it will find its way through the efferent arterioles and then into the peritubular capillaries. From the peritubular capillaries, it will continue to move through the interlobular and then segmental veins. Now, once we get into veins, now we're heading back, right? So arteries go, so it all starts with the heart, right? And when we're going away from the heart, we're going to the kidneys, right? In this case. Remember, if we're going away from the heart, this is all the job of arteries. Once the blood is filtered, now we're going to be leaving the kidneys. Even though we're inside the kidneys still, we're on our way out. We're going to go back to the heart for general circulation. Well, anytime we're going back towards the heart, we're going to be traveling in veins. All right. So halfway through, when we're inside the kidneys, we still can be going towards the units of filtration. And if that's the case, we're traveling in arteries. But once filtration is complete, we're going to take that filtered blood and now we're going to head back out. We're always going to be in veins. So it's halfway through the process that the blood vessels are referred to as arteries, and then it switches to veins. All right, so what's happening? This is a slide that comes up a lot. We see this quite a bit, this slide in this presentation. So what is happening? Well, all right, well, the blood has to come in unfiltered, and it comes in through the renal arteries. All right. And then from the renal arteries, yeah, that's here, right? Coming in, we're going through the medulla in the interlobular arteries, and we're trying to get up into the cortex here. Well, here we have the interlobular arteries, and we're going up. Now we're in the cortex, and we're going to go into what's called the afferent arteriole. The afferent arteriole leads the blood into a circular arrangement of capillaries that allows the blood to kind of spin like this in circular motions. This circular arrangement of capillaries that causes the blood to spin around is called the glomerulus. Now remember, if the blood is spinning around like that, it's going to be experiencing some centrifugal force. And what this does is it causes any of the waste products that are in the blood to be forced outside. And when they are forced outside, they collect in these little tubules here. So these tubules are filling up with waste products in the form of extra water or nitrogenous waste, salts. And then the blood will leave this area and exit the glomerular capsule and travel in through what's called the efferent arteriole. So the efferent arteriole then takes the filtered blood and it allows it to leave the beginning of the nephron, which is called the glomerular capsule. It's from here now that this blood will go over these tubes over here. These tubes over here are very important. These tubes, this is where the filtrate would be heading, right? The filtrate is all the stuff we just took out of the blood. It's going to be traveling through these tubes over here. But here's the thing, a lot of that stuff we just took out of the blood, some of it's good, and we need to put it back in the blood. So these yellow tubes here, actually they're labeled up here, the proximal convoluted tubules, are carrying waste products that were just removed from the blood, but they're also carrying good things that we need to put back in the blood. For example, like glucose was just taken out of the blood. We can't have the glucose taken out of the blood. We need it. Amino acids were taken out of the blood. We don't want to rid the blood of amino acids. So it's in this area right here, the proximal convoluted tubules, that the blood will take the good things back. All right, so from here, the blood will then kind of go back and forth over this tubule. And as the waste products are traveling through this tube, this is now going to be referred to as the loop of Henle. It goes down. Now we're in the medulla region. And then the filtrate is going to come back up. It's in this area that the blood goes from traveling in arteries to traveling in veins. So this is the transition here. All right, so where are we going next? Well, before we could exit, the blood will drop over here. It'll make a pit stop at these tubes. This is the urine will eventually make it through these tubes. Now look, these tubes are a little bit further away from the beginning. For that reason, we call these the distal convoluted tubes. But the blood will go over that way. And what it'll do is it'll drop off any wastes that it still needs to get rid of, but couldn't get rid of in the beginning because they were just too big. So we're talking about waste products, maybe that are left over from drug use or prescription drug use that need to be removed from the blood using a little bit of energy. All right, so then the blood would be completely filtered by the kidneys, and now the blood is clean. So it would be time to exit, and it exits through the renal veins. And the renal veins would then go back down through the medulla, through the renal pelvis, and then through the hilus, and then it goes back into circulation. So blood goes in unfiltered, dirty. It goes through this process of being filtered at these structural units. What are we looking at here? This is a filtering unit of the kidney. This is called a nephron. All right, and three things are happening right here. Number one, the first thing that happens right here, this is called filtration. Number two, this is everything's coming out of the blood. Number two, we have happening at the proximal convoluted tubules, we're taking some of the good things and putting it back in the blood. This is called reabsorption. And then lastly, over here at the distal convoluted tubules, we have a third process. This is where the blood dumps off larger waste products. This is called secretion. And then whatever's left over is going to be urine from the distal convoluted tubules. It all drains into these large collecting tubules. And then the large collecting tubules all converge in the renal medulla, and that's what causes the renal pyramid appearance. All right. And then all this urine will drain from the collecting ducts through the pelvis and then end up going through the ureters. Each kidney has millions of nephrons. You have enough filtering units in one kidney to do the job, which is why people are able to donate kidneys and still manage to have enough filtering capacity to live a normal life. All right, so it's that glomerulus that is a knotted or circular arrangement of capillaries, and that's where filtration is happening, right? This is the site of filtration at the glomerulus. So number one, that's the first process, filtration. So everything is coming out of the blood that's small enough to, right? All these different things are leaving the blood and they're finding their way from the blood vessel into the tubes of the nephrons that surround the glomerulus, which is called the glomerular capsule. So these are tubes from the kidneys. Let's keep going here. All right. So as the wastes are removed, remember, this is happening at the glomerulus. This is the glomerulus, between the glomerulus and the glomerular capsule. All right. This is called filtration. So after this, some of the necessary things like ions and nutrients need to be returned. Well, this is not filtration. When the nutrients are returned to the blood, this is actually at the proximal convoluted tubules, and this is called reabsorption. Reabsorption. All right. So the nephron tubules have three main parts. We have the glomerular capsule, which is where filtration is occurring. So where the wastes are leaving the blood and going into the tubes of the nephron, that's called the glomerular capsule. But from there, we go through three more sections. We go through the proximal convoluted tubules, down the loop of Henle, and then into the distal convoluted tubules until everything drains into the collecting ducts, right? The collecting duct is what gathers all the wastes and drains it down towards the renal pyramids. If we are dehydrated, do we want the water being removed from our blood? No, not really. We want to preserve water if we're dehydrated. So there is a hormone that communicates with the kidneys and tells the kidneys, don't release all that water in the urine. We have to preserve some of it. So the water can be reintroduced from the nephron tubules back into the blood vessels. And this happens either at the loop of Henle, or it happens through the walls of the collecting duct. And this is controlled by a hormone called anti-diuretic hormone. All right. So water balance is maintained as a result of, this hormone, but specifically through the walls of the loop of Henle and the walls of the collecting duct. So where does urine formation begin? It begins at the site of filtration. So it begins at the glomerulus. At the glomerulus, all the wastes and the good stuff are removed from the blood in the form of what's called filtrate. And that filtrate ends up in the tubes, right, that surround the glomerulus. This is called the glomerular capsule. Some books also call it Bowman's capsule. Bowman's. Okay, so this is called filtration. But then again, we could dump some things off later on at the distal convoluted tubules, and we would refer to that as active transport because we're using energy to get those products out. All right. So the first step between the glomerulus and the glomerular capsule is filtration, glomerular filtration. What's coming out of the blood? Water, nitrogen waste, nutrients, salts, all forced out of the blood at this point. Now, we don't want to lose nutrients in our blood. We might not want to lose water in our blood. We pretty much do want to get rid of the nitrogen waste, but we don't want to get rid of everything. So then we would have to take that back. Again, this is happening as the blood is entering the kidneys, right? It's coming through the renal artery and then the interlobular arteries and then the afferent arterioles, and then it spins around in the glomerulus. So it's between the glomerulus and the glomerular capsule right here that filtration is happening, okay? And what's the result? The result is everything is coming out of the blood and getting forced into this tubule that surrounds the glomerulus, which is called the glomerular tubule or Bowman's capsule. All right, but remember, there's nitrogen waste in there, but there's also good stuff in there. So it's in the proximal convoluted tubules that the blood would then have to go and revisit. Right, it's going to revisit these tubules and take those good things back before it goes down the loop of Henle. Remember, the loop of Henle is the site of water balance. So water is going to be exchanged here in the medulla section as the descending limb of the loop of Henle extends it down into the medulla region. But again, water could also be balanced over here through the walls of the collecting duct. And this is all going to be controlled by the hormone. So glomerular filtration is the first step. How do we get everything out of the glomerulus and fill the tubes of the glomerular capsule? How do we get that to happen? Well, we have to increase the blood pressure inside that circular arrangement. Okay, so how do we do that? Well, that's what the circular arrangement is really there for. It increases the pressure as blood is spinning around. You might experience this if you go on a carnival ride that spins around. It increases the pressure in the form of G-forces, right? It means if it spins fast enough, sometimes you even stick to the walls. So as the blood is spinning around the glomerulus, blood pressure increases to the point where it's high enough to force the liquid portion of the blood through the walls of these capillaries. And what's going to happen is it's going to fill the glomerular capsule. However, the glomerular capsule is not going to be completely empty. There's already going to be fluid in there from before. All right. So the pressure inside the glomerular capsule must be low enough to allow more fluids to be forced in. So this pressure up here has to be greater than the pressure that's already in the tubules that surround it. Then we have to overcome the osmotic pressure of the blood, specifically in the peritubular capillaries. The osmotic pressure of the blood in the peritubular capillaries has to be high enough to draw the water back into the capillaries from the nephron tubule. And there's a good picture that describes that. All right, so let's look at this. So here we have the unfiltered blood from the afferent arteriole coming in. And now we're going into the peritubular capillaries of the glomerulus. So what's going to happen? This blood is going to start spinning around and around and around through this circular arrangement of capillaries. And this is going to increase the blood pressure as this blood continues to spin around and around and around in here. Now, here's the problem. There's already fluids in here. So the pressure that is exerted on the blood here has to be greater than the back pressure from the fluid that is already in there. If it is, then we're going to have materials, plasma, and other materials, glucose, amino acids, nitrogenous waste, filling up this space. But here's the thing, as the blood loses plasma, it's going to become more concentrated, right? So there's going to be let's call this the blood becomes thicker, right? With solutes, because it's losing a lot of its liquid. So this becomes a hypotonic. And this becomes inside, the blood becomes hypertonic. Well, we know about what hypertonic solutions do. They pull water back. They pull plasma back. So what is the real net result? What is the amount of solution that is going to be leaving the blood and actually making it into the proximal convoluted tubules? Well, it's the amount of solution that could come out, right? Minus the back pressures from the fluid that's already in here and the osmotic pressure. So the net filtration pressure is the sum of these three forces pushing fluid into the nephron, while second force, the fluid that's already in there, and the osmotic pressure are going to be pulling water back from the nephron into the blood. All right. The glomerular pressure, the blood pressure that's inside this glomerulus, has to be higher than your systemic blood pressure, your systolic blood pressure. All right, it has to be higher than that. And we get it higher than that through the kinking and twisting of those blood vessels. All right. So again, this is just a repeat of the last two slides. In order to filter the blood pressure inside the glomerulus must be high enough to overcome the pressure of the fluid that's already in there, as well as the osmotic pressure of the blood itself. Because remember, hypertonic blood wants to pull fluids back. If your body's blood pressure drops below 60 millimeters, which is very low, then you're not going to be able to generate enough force in the glomerulus to promote filtration, and then your kidneys will fail. All right, so after the blood leaves the glomerulus, it's going to be heading over to the proximal convoluted tubules for the second step in urine formation, which is called reabsorption. Because remember, everything that's coming out isn't everything that we want to get rid of. As the filtrate goes through the filtration process, as the blood goes through the filtration process, filtrate consists of ions, water, nutrients. These things sometimes need to be returned to the blood, and this is called reabsorption. So this is the second process. Remember, reabsorption, we saw this in the small intestines when we're absorbing nutrients. We have these structures that promote absorption, and they were called villi. We're going to see villi again here because the cells of the proximal convoluted tubules are covered with microvilli. Remember, microvilli increase the surface area available for absorption. And here, this is the same case with the microvilli in the small intestines, the columnar epithelial cells in the small intestines, increasing the amount of area that's available to absorb nutrients. Well, here we see it again in the cells of the proximal convoluted tubules. We have a small amount of space. We want to maximize the efficiency of which these cells can pull nutrients back into the blood. All right, so the essential ions and water are sent back into the blood by osmosis and diffusion. Of course, glucose returns to the blood. We don't want glucose leaving the body in the form of urine. We want to keep the glucose. The last step happens at the distal convoluted tubules, and this is called secretion at the distal convoluted tubules. And it's at this step that we have to remove items from the blood, kind of like last minute, right? Because maybe they were too big. We couldn't get them through the walls of the capillaries in the glomerulus. So in order to get these larger items out, they have to be secreted, right? So we have to use energy. Maybe these substances were too large to filter out in the early stages. So steroids or the breakdown of drug products, either over the counter or prescription or recreational drug products, will be added to the urine. Once the filtrate passes through the nephron and then the collecting ducts and reaches the renal pelvis, before it enters into the ureters, well, that's at that point that we would refer to this as urine, right? Once it's reached filling the collecting ducts, it's urine. Sometimes we have concentrating salts in the urine, and they could develop into stones that could clog the pathway, causing a lot of pain. These rock-like masses are composed of calcium. And sometimes they could grow large enough that they can completely block the flow of urine out of the kidneys. So from the renal pelvis, the urine will travel down the ureters to the urinary bladder. The urinary bladder is hollow, and it's lined with what are called transitional epithelium. And that allows these types of cell allow for the organ to stretch without tearing. So stretching is important, but going back to the original size is good as well. We call urinating the removal of urine from the bladder, and this is going to be happening through this tube called the urethra. So that extends from the bladder to the exterior of the body. Here's an x-ray. Here, it's up here. We see the kidneys. We have the right kidney and we have the left kidney. And you could see in here we have the renal pyramids up in here. And you can see the collecting ducts all converge into the renal pelvis, and then the urine leaves through the ureters, which extend all the way down to the bladder. Here's the right ureter. This bladder looks empty. This bladder looks full. UTIs would be urinary tract infections. This is when bacteria from outside the body can travel up the urethra and form colonies in the bladder. This results in pain, especially while urinating or bleeding. Usually taking antibiotics could clear up UTIs. And women are more susceptible to UTIs, and the reason is because the urethra is much shorter in women and more likely to reach the bladder. If we look at the urethra from the bladder, this is it. So bacteria from the outside could reach the bladder a lot easier in women compared to men. The bladder is up here in men. So it's a longer distance that the bacteria have to travel, and they're more likely to be greeted by white blood cells along the way before they even reach the bladder. A couple of different kinds of incontinence. Incontinence can occur in many different age brackets, many different genders, social levels, but it's more common in elderly women. This could be the reason for that could be because of chronic UTIs or side effects of medication, the weakening of the muscles that are involved in urinating. Sometimes men have a prostate gland that becomes enlarged. So there's many different reasons. Stress incontinence is leaking of urine during physical exertion. So if you're jogging or jumping, there's leaking. Urge incontinence is the inability to quell the urge to urinate. And then we have overflow incontinence. If you wait too long and the bladder becomes too full, well, like we said, the muscular weakness could cause that overflow type of incontinence. That's more common in people that are older. In terms of water and salt balance, we can do this, like we said earlier, between the walls of the loop of Henle, as well as the walls of the collecting tubule. So if you're in a dehydrated state, the water, before it drains down into the urinary bladder, the water that's in the urine, by osmosis then would leave through the walls of those tubules and re-enter the blood supply. And this is all controlled by a hormone called antidiuretic hormone. So if you are not drinking water, for example, and your body becomes dehydrated, you are still going to produce urine, but the urine is going to be more concentrated, right? It's going to appear more dark yellow. And the reason is because you're pulling the water from the urine and putting it back into circulation. For blood pH, we need to keep the blood pH between the range of 7.35 and 7.45. If the blood pH extends above 7.45, that is called alkalosis. The state of alkalosis is not very good, and if it goes below that, this is called acidosis. And neither of these things are very good. In fact, your kidneys will work to reverse this if this is happening, because we have bicarbonate ions that we store, and then we have hydrogen ions that we store. So hydrogen ions are acidic. So if the blood is ticking too high, the kidneys would release those acidic hydrogen ions to make that come back down to normal. And if the blood was becoming too acidic, we would release the bicarbonate ions to reverse that. So we do have buffers in the form of these two ions that control the blood pH. The main organs that control blood pH are the the lungs. However, sometimes people get into respiratory distress and the lungs aren't working. So the kidneys will try to compensate um, by releasing these individual buffers, depending on what type of situation we have. This is called metabolic compensation. This is kind of, I already talked about this, but this is the difference between producing a dilute urine, which is more of a clear urine, compared to producing concentrated urine. Concentrated urine would be more of a darker yellow. So this is more like the urine that is the first urine of the day after you've been sleeping for, let's say, 10 hours and you haven't been drinking at all. So the cells of the distal convoluted tubules, the cells of the collecting ducts can be controlled to reabsorb water in the presence of certain hormones, right? ADH. Water can also be reabsorbed through the walls of the urinary bladder. All right. So this is why, as we pull this water out of the urine, it's going to appear darker. It's going to become more concentrated. But as we're going throughout our day, many people are drinking water all day long and they become overhydrated. All right. So if that's the case, then water is not really going to pass back into the bloodstream across the walls of the convoluted tubules or the collecting tubule. All right. The water proportion inside the urine is going to increase, and the urine that is reaching the collecting duct will be more dilute and will be more clear. All right. And again, it's the ADH hormone that causes the reabsorption of water back into the bloodstream. All right. So we could control urine volume. If we pull water out of the urine and reabsorb it back into the blood, that'll decrease urine volume. All right, so this is coming from the posterior lobe, the posterior pituitary gland, which is up in the brain. And this causes the cells of the collecting duct and the distal convoluted tubules to take water from the urine and put it back into the bloodstream. This is another example of a negative feedback loop. Another example of maintaining homeostasis. And it all starts with an increasing ion concentration of plasma and interstitial fluid. So when we have increasing ion concentrations, that means there's not enough water. We have cells in the brain that are detecting that in the hypothalamus. Okay, so the cells detect that. They detect that you're dehydrated. The cells of the hypothalamus will communicate that to the pituitary gland. The pituitary gland will release antidiuretic hormone. There's effectors that are going to be receiving antidiuretic hormone that are embedded in the walls of the distal convoluted tubules and the collecting ducts. And it's going to cause the water that's in those tubes to be returned back into the blood, therefore reversing the original problem, right? What's the original problem? There's the ion concentration in the blood is increased, but when we add more water to the blood, it decreases the ion concentration. Okay, so this is why we call this a negative feedback. We're reversing the original problem. On this slide, we see interactions between different hormones. and regulating certain things. So, for example, ANP and BNP regulate the reabsorption of sodium. The idea is when blood goes through the filtration process, sodium is usually removed. Sodium is a normal constituent of urine, right? Salts are a normal constituent of urine. However, we don't want to get rid of all the salts. We need to put some back. So, aldosterone, ANP, BNP work together. ANP and BNP increase blood volume and blood pressure. Aldosterone causes the excretion of potassium ions into the filtrate, into the urine, and the reabsorption of sodium ions from the urine, right? Putting it back into the bloodstream. All right, so this is how we maintain a balance between potassium and sodium ions. Caffeine has an effect on urine production as well, as does alcohol. They both increase urine production because what they do is they decrease the production of the antidiuretic hormone, both of them. Like we said earlier, the blood pH needs to stay within this narrow range of 7.35 and 7.45, and we do that primarily through this buffer system. Bicarbonate buffer system includes using bicarbonate ions as well as hydrogen ions, and this is how the kidneys can work to compensate fluctuations within pH, blood pH. The lungs are the real regulators of blood pH as they work to remove carbon dioxide. Remember, carbon dioxide is an acid. Acid. So as carbon dioxide levels build up in your body, your blood will become acidic and this number will drop. Your blood will go into what's called acidosis, blood acidosis. However, if you are releasing too much carbon dioxide, your body is losing too much acid, and your blood will become basic or alkalytic, right? So you go into what's called blood alkalosis, which is the opposite problem. But then, as this happens, the kidneys would try to do their thing to help counterbalance. All right. So if the blood is too acidic, the kidneys will release hydrogen ions, meaning that they'll put them in the urine, get them out of the body, and they'll add bicarbonate ions back into the blood. If the blood is too basic, then the opposite will happen. The kidneys will put hydrogen ions, the acetic hydrogen ions, into the blood, meanwhile getting rid of the bicarbonate ions in the urine. So there is a buffer system. And again, this is the negative feedback loop that kind of describes the ongoings of maintaining blood pH using hydrogen ions and bicarbonate ions. So again, this one over here talks about the blood pH decreasing. So this is called acidosis. And then if blood pH increases, it's called alkalosis. And the opposite would happen in both situations. In acidosis, we excrete hydrogen ions and absorb the bicarbonate ions. So if you look at this table comes from the textbook. It talks about the normal constituents of urine. Under normal conditions, the volume should be between 1 liter and 2 liters over a 24-hour period. It talks about normal color, normal turbidity, that's how clear it is, and odor, normal pH, and specific gravity. Specific gravity is a measure of solutes that is in solution. So it begins with a specific gravity of 1. Water has a specific gravity of 1 because it doesn't have any solutes and it's pure, right? But as we add solutes to the water, the specific gravity reading increases. So the specific gravity reading of normal urine should be close to 1 if it's extremely dilute. 1.001 up to 1.035, which would be more concentrated. What do we not want to see? Well, we don't want to see albumin. We don't want to see proteins. There's a protein. The reason being is proteins are too big. We don't want to see hemoglobin. Hemoglobin is on the surface of red blood cells. And these, we would have hemoglobin in our urine as a result of broken down red blood cells. We don't want to see whole red blood cells either. This is a result of bleeding, by the way. Whole red blood cells are also, just like albumin, they're too big. They shouldn't be leaving the capillaries at all through the walls. So if something is reaching the urine that is really too big to be filtered out, the reason for that in these two cases is you have high blood pressure. The pressure inside the glomerulus is so high that it's forcing even these large items out. White blood cells would indicate you have an infection. Glucose, if this is leaving through into your urine and being excreted in your urine, that's an indication that you have diabetes. All right, so these abnormal components of urine kind of tell you something's wrong. All right, so again, albumin is too big. High blood pressure, says here. Hemoglobin indicates you're bleeding somewhere. All right, so the red blood cells have been present in the urine long enough that they're starting to break down. White blood cells, of course, this is true anywhere, but in the urine indicates that there's an immune response happening. And that's probably the means that you have a urinary tract infection. Glucose, again, if it's in your urine, it'll cause your urine to smell sweet, and that's another sign of diabetes. Casts are any small plugs of materials that might be shaped like the nephron tubules that build up in the tubules and then get forced out. They're usually in the form of minerals, but they clog the PCTs and the other loops. All right. These cause serious problems or nephritis or glomerular nephritis. This itis. This is just inflammation. Inflammation of the nephron or inflammation of the glomerular tubes. All right, it's important for us to keep our kidneys functioning normally because we have to maintain blood composition, right? We have to maintain blood homeostasis, and we wouldn't be able to maintain blood homeostasis if it wasn't for the functioning of our kidneys. Kidney disease is most commonly found as nephritis, glomerular nephritis. These are both kind of acquired disorders, or polycystic kidney disease. This is inherited, right? So you would be born with this, and what happens is cysts would be forming inside the kidneys, and these cysts, as a result, would then destroy the normal kidney tissue. A patient that would have polycystic kidney disease would require dialysis for a certain point, but probably would benefit from a kidney transplant. Glomerular nephritis is when the blood circulation is being blocked into the glomerulus because of a swelling of the nephrons. If the whole nephron is swelling or inflamed, we refer to that as nephritis. So here's the thing. If the kidneys are not able to filter blood, the toxins in your blood will build up, right? So those nitrogen compounds, those toxic nitrogen compounds in your blood that the kidneys are supposed to eliminate will build up, and you will become sick, very sick. And if it doesn't, reverse itself, then you could die from something like that. So we do have dialysis, and dialysis would be done through the blood in a machine, and it will allow the exchange of liquids between two solutions through a dialysis tubing, which is a semi-permeable membrane. So if the kidney shut down, you have to continue with dialysis, or your blood will become too toxic and your body would just eventually shut down. So these machines allow for this dialysis, this exchange of materials between the blood and the nephron tubules, or urine, really urine production is happening now outside the body. All right. So with hemodialysis, how it works is blood is taken out of your arteries and passed across the dialysis membrane. The toxins would then diffuse into the prepared solution and be removed from the plasma. And then those would not be allowed to be put back into the blood. All right. So it's a carefully prepared solution that prevents the diffusion by putting the same concentrations of components in the dialysis fluid as they should be in the blood. So if there's an elevated level of toxins in the blood, they'll go down their concentration gradients, leaving the blood, entering into the dialysis machine. All right. So after that's all over, as the blood goes through the dialysis, the dialyzed blood then is sent back into the body. So it takes a couple hours. You're sitting there for sometimes 3 or 4 hours, and this has to be done several times a week. Kidney transplant are pretty common. With kidney transplants, however, what you're doing is you're taking another individual's organ and putting it into your body. So the risk is comes in the form of an immune response, right? So if you put anybody's tissues inside of your body, the white blood cells, it's only a matter of time before that they will recognize that and want to attack that, right? So how do we combat that? Well, if you were to have a kidney transplant, you would have to take drugs to dampen the immune response, right? And these are called immunosuppressants. So that would be your life at that point, is taking immunosuppressants and avoiding contact with people, right? Because if you're on immunosuppressants to dampen the immune response so it doesn't attack your new kidney, well, now you become susceptible to germs. And if you continue to live a life, that's close contact with crowds, you're going to be getting sick a lot more. So, all right, this concludes the notes. Stay tuned for the lecture, for the lab, and we'll do some more kidney talk.